Today, we have a particularly timely Grand Rounds, a training on how to be an upstander, given by our own Dr. Jean-Marie Alves-Bradford. We are going to be having participation in old-fashioned way via hand raising throughout this workshop. For those of you who are on the Zoom, you can participate with suggestions in the chat, and they will be passed along to me by my trusty co-director, Dr. Muley. In general, if you're participating via Zoom, you can post questions at any time during the talk in the chat feature. And we encourage trainees to participate at any time throughout the talk, and we will hold space for trainee questions in person and online. So please indicate on Zoom if you're a trainee. I would now like to ask Dr. Cristiane Duarte, the Ruan Professor for the Implementation of Science for Child and Adolescent Mental Health at COIMC, Research Science at NISP, and Director of the Center for Intergenerational Psychiatry, member of the Office of Fairness, Inclusion, and Professional Development, to formally introduce our speaker.
Hello, everybody. It's a pleasure to be here I'm here on behalf of the Office of Fairness, Inclusion, and Professional Development to introduce our very own Dr. Jean-Marie Alves-Bradford. Dr. Alves-Bradford is a professor of psychiatry at the Columbia Medical Center, and at our medical school, she's the Associate Dean for Student Affairs, Support, and Services. She's also the inaugural Dean of Medical School Professionalism in the Learning Environment, and she's at the New York State Psychiatric Institute. She is the Director of Integrated Care in Washington Heights. Dr. Alves-Bradford is a graduate of Harvard and the Albert Einstein College of Medicine. She has been a Columbia faculty member since 2004, following the completion of her residency in psychiatry at our department, where she also was chief resident. She has over 20 years of experience in medical education, faculty development, patient care, and psychiatric clinical service leadership. Her accomplishments are many, and they are widely recognized, including, and I'm just going to cite two very recent awards, the Virginia Apgar Academy Award and the Martha Hooven Awards. Both of these awards, they celebrate her excellence in medical education and her leadership in developing programs that improve equity and inclusivity in our institution and the excellence of our learning environment. She created a novel clinical service that integrates primary care and outpatient in our outpatient mental health clinics. And she also directs a clinical rotation for our residents to practice in these integrated settings. She directs a longitudinal health equity and justice curriculum for psychiatric residents. Dr. Alves-Bradford is not a stranger to these grand rounds. From 2020 to 2022, she launched and led the Addressing Structural Racism Grand Rounds series during a critical time for our department. And then she stepped up as the inaugural director of this very office that I'm speaking for today. I'm sure you would join me, and we are all incredibly grateful to Jean-Marie for all the work that she has done in this space, her leadership, and her vision. Today, she will share with us an Upstander training that she created, a powerful curriculum now being shared across the medical school, and a resource that today feels more important than ever for all of us. I'm sure you would agree with me. Please, let's welcome Dr. Alves.
Thank you so much, Cristiane. That was such a warm and really kind introduction. I really appreciate it. It's wonderful to be here with so many good friends and people I've learned so much from and worked with. So I'm excited to present this work today. If you wouldn't mind, if you would scan this QR code and do a pre-survey, that would be really helpful. It helps to improve this content. This is part of a series that delivering across the different departments to improve our learning environments. And so I'd like to hear from you guys about how your thoughts. Okay. So I don't have any financial disclosures, but I did want to acknowledge just the wonderful team of people that I've had an opportunity to work with in developing this content, including several medical students who were medical students, and now 3 of them are psychiatry residents. And also just the wonderful financial and kind of time support that I had from the Office of the Vice Provost at Columbia, and also from the Virginia Apgar Academy. So after today's session, you'll have an opportunity to, you'll be able to recognize elements of healthy learning environments, define student mistreatment and hostile learning environments, and we'll practice Upstander skills as a way to mitigate those student mistreatment and hostile learning environments. And we'll do that by applying those skills to using published frameworks to sample cases. So this is an example of a system-wide Upstander skill, and it's important. It is timely to talk about Upstander skills. It's a very difficult time for our institution, and it can be even more difficult when trying to deploy Upstander skills in such times of uncertainty. This is the statement of partnership and humility. It was really led by one of our own residents, Laura Benoit, who was a medical student at the time. And we do have inclusive curriculum guidelines, and I did consult those. I also invite you to just email me or enter. We ask our students to enter feedback on our learning environment portal as well, to offer feedback about our sessions. So clinical learning environments refer to various physical sets, contexts, and values in which students and trainees receive education. And healthy learning environments, we'll talk about a number of different examples and ways to foster healthy clinical learning environments. We want to optimize values such as inclusive learning environments. We want respect, resilience, integrity, and excellence to be part of those learning environments. We want to mitigate those challenges to learning and patient care. For example, learning mistreatment, microaggressions. And we want to develop skills and processes to react to and report challenging events and behaviors in the learning environments. And also to identify exemplars who role model key character traits. So our institution has set forth our values in both at NYP through our Respect Credo and also at CYMC through the CYMC Cares, which talks about these values that we hold: respect, civility, acceptance, ethics, and support. And these are key characteristics of healthy learning environments. This is just an example of our learning environment policy. It's available anytime you want to go to it, just by putting in VP&S learning environment policy in any search engine. And it defines some of the things that you'll hear today. What is mistreatment? What are hostile learning environments? What is our process at VP&S for addressing those and managing and surveilling the learning environment? And it also has some tools for educators as well, which I'll show you a little bit more of. So mistreatment is directed directly at a student, and it includes public humiliation, asking students to do acts of personal service, sexist or racist remarks, physical harm, unwanted sexual advantages, or denying a student either a grade or a learning opportunity or training opportunity based on some characteristic of themselves. Those same behaviors directed at anyone else than a medical student is classified as hostile learning environment. So if those behaviors are directed at a patient or a hospital team member, then that the student's witnessing, then that's a hostile learning environment. And the other category of hostile learning environment is when students are consistently ignored. And sometimes this happens because people are a little bit afraid of like doing mistreatment or just for other reasons. And so they're like, okay, I'm not going to really interact so much with the medical student, or they're too busy and they can't engage. And then that becomes, and so the medical student really doesn't have any learning, but they're part of our learning environment. We want to teach them. We want them to learn. So the AAMC administers this graduation questionnaire annually each spring to our graduating seniors. So our graduating seniors of class of 2025 are filling it out in the next month. And this is it allows us to benchmark ourselves against all other medical schools in the country, because everybody in the country is filling this out. So this is the data from 2024. About 85% of our students fill this out. So we have a healthy response to this annually. And you can see, I'm just highlighting some of the things that relate to learning environment and professionalism. We do great, in lots of other ways. People love our clerkships and our experiences here, but I'm just going to highlight a few areas where we could, do a lot better. And so our students, when they're asked about the emotional climate, we're only in the 50th percentile of all schools. When they're asked how much is there a disconnect between what they're taught about professional behaviors and what they see being demonstrated, we're below the 25th percentile. So these are things, obviously, we want to work on. This, again, is also another set of questions that they're asked on this graduation questionnaire. And then you can see here, we're really below the 50th percentile in most of the faculty professionalism domain. And that includes, and really at the lowest levels, like below the 10th percentile in some questions related to being respectful of patients' dignity, autonomy, taking time to an effort to explain information, advocating on support of patients, respecting diversity, and being respectful of other health professionals. So this is really, kind of difficult data to sort of, digest. And this is something that we really want to try to work on. So we've had an opportunity to sort of talk to our students. Okay, so we know that you're having wonderful experiences. And so what do you think would be helpful to sort of, what are examples of models of kind of healthier interactions that you've had with faculty? This slide is just to show that it's not just a student problem. It's not just like, oh, the students are very critical, they're from a different generation. If this is also something that our patients are asked about. So these items that are on the graduation questionnaire about being respectful of patients, actively listening, and taking time and effort to explain information is also very similar to questions that are being asked of our patients, like, did the physician or did the team members show respect for what you said? Did they listen carefully to you? Did they explain things in a way that you could understand? There's many reasons, not just our students, but also that we want to really pay attention and try to improve this data. Here's some of the things that our students did say when we sort of said, what are the examples of when things worked really well, when you felt like there were respectful interactions in the learning environment? And our students said, when attending set expectations, explain team preferences or tasks. They gave this sort of analogy, like, I'm like a rotating chess piece and I'm just like moving around and I have to work with lots of different teams and get to understand lots of different teams and the way they function and then what they want. And it's really hard to know what they want. So when teams sort of set expectations sort of more explicitly, it's really helpful. So they might say, here's how I like presentations to be done. Here's the kind of focus that we want to focus for this interview, or here's how here's how thorough I would like the chart review to be done, or how I expect you to do it. That's really helpful for our students. And when they provide actionable feedback before the end of the rotation so that the student has some time to implement that feedback. So I'm frequently tasked with providing feedback to our students, and it's the worst when the faculty member will tell me a lot of what happened, but then on the evaluation form that the student receives, there's very little actionable feedback. It's very vague and non-specific, but there's a lot of specifics that, the faculty members. So the more that you can put into your evaluations when you're interacting with our trainees, please do so. So it's really, the students want to get better. They want to learn. They want to understand how to improve and to differentiate themselves from the other students as well. And then also when a faculty member might bring a student in to see a physical exam finding, review imaging, there's nothing like being able to be reading about the students, reading about these things, learning about these things. And then when they actually get to see it demonstrated in a patient and have that explained by you, it's really fantastic. And setting realistic expectations early on so that there's opportunity for built-in goals for growth. And of course, not using the student as an example of what not to do. They're new, they don't know a lot of things, they're learning, and they will make mistakes, but obviously we don't want to highlight that in a negative way, just want to provide feedback in order for growth. So as we turn to navigating challenges in our learning and patient care environments, we want to just think about microaggressions and how we can respond to those. Unfortunately, so microaggressions are brief everyday exchanges that send denigrating messages to certain individuals because of their group membership. Unfortunately, it's commonly experienced by not just medical trainees, which is true, they commonly experience that, but also healthcare providers in general. Commonly experience microaggressions on behest of lots of people, patients, by other staff and team members. And unfortunately, the impacts are great, they can range, they can be mild or they can be moderate or severe, but they can include stress, burnout, depressive and anxiety symptoms, cognitive load. It can really interfere with what the student or trainee is doing at the time, takes them out of what they're doing and learning. Sort of they pause and they think, hey, was that just targeted toward me because of who I am? Or was that just a offhand comment? And it really takes them out of what they were doing. They're here to learn. It can interfere with the team functioning. And so they're, again, like, hi, I wonder what my colleague really thinks about that. Do they think that applies to all people? Is it just for one person? So they're really then now, again, processing and trying to focus on what just happened. And meanwhile, they're trying to go on and do and to learn or provide care. And also the quality of care, right? Our patients also receive microaggressions and are on the receiving end as well. And that can lead to a lack of trust in the healthcare system and maybe also avoidance of some places or delays to care. So bystanders are present. That doesn't mean they actively are doing anything. The bystander effect is, unfortunate that the more people are around, the less likely any one individual is to provide care. Every sort of a diffusion of responsibility where people think somebody else has kind of got this or is gonna take care of this. And so we want to be upstanders, right? Upstanders speak or act in support of an individual or a cause, especially someone who intervenes on someone who's being attacked or bullied. There's a lot of different steps that are important. You just have to recognize that something just happened that needs action. Lots of times with microaggressions, people actually don't know or didn't realize that even was something that landed differently, that was hurtful. And so even just recognizing that is a step to be able to provide help. You also then have to assume the responsibility. Again, that bystander effect kind of is that diffusion of responsibility. Even for us, like we're trained healthcare providers, we want to go to the action, we want to help people. But when it comes to some content related, there's lots of reasons why we're less likely to intervene when it's around bias, when there's hierarchy involved. It's more uncomfortable for us to intervene. We're just talking about that right now. It's really hard to intervene when you're seeing things in the world that are happening as well. And then you have to know the appropriate form of assistance to be able to provide help. And the why that we want to do that is, we want to support our trainees, our patients, our colleagues. We want to maximize the safety of our workplaces and our learning environments. And also national organizations have, taken note and incorporated these kinds of skills into competencies and program requirements. So you can see them reflected in the AAMC's competencies. You can see that reflected in the ACGME competencies and common program requirements, in milestones, in related to individual patient care and communication skills, and also related to team-based communication skills. And how we do this, how do we perform these new communication skills that we're going to try to practice out today? We want to do it in a way where we're, again, focusing on respect, focusing on the fact that multiple perspectives are welcomed. We want to own our intent and impact, not intentionally try to hurt one another, speak from our own experience, and accept that there's a lack of closure. So One thing that's important to do is to talk about what happens if you are the source of microaggressions. We're all the source, including myself. So it's helpful to just have a response on hand when you do, and you may not even know that this is happening. So if somebody points it out to you, or you sort of see that something happened in the environment, you want to be able to have a response. The tendency is really for some people say to deny or to feel ashamed or to feel blamed. There really isn't shame or blame. This happens to everyone, right? So there's like systemic things in our environment that we're picking up, cues, messages, the way our system is structured. And so there's lots of reasons why, even when it's sort of not congruent to what you think, you might end up saying something that might be harmful to someone. And so having a response on hand is really good. The triangle model I really like by Dr. Kupiri Ackerman Barger. Christiane mentioned our grand rounds that are addressing structural racism. She was one of the speakers, and that's available for you to watch if you're interested in that. And I like it because she uses the terminology as pretty neutral. There's a recipient of microaggressions. There's a source. That's where the microaggressions are coming from. There's no blame or, in those words. And then there might be a bystander who we hope to turn to an upstander. So if you're the source, you want to just acknowledge that something happened. Again, lots of this goes unacknowledged because it's kind of the elephant in the room. Nobody mentions it, but people are thinking about it. It's distracting, and it can interfere with the team. You want to seek feedback and information, oh, I see. Because again, you may not know exactly what is the content behind that kind of caused this reaction. So I want to learn more. And then you want to say sorry, to apologize as well. And to think that this is really important, and I'll talk about this a little bit more, but to focus on the impact and not the intent. Because oftentimes the tendency is say, oh my gosh, I didn't mean to say that. That's not what it was meant. And, then to be a little bit defensive. And really that takes the focus to you. What we want to do is put the focus on the recipient, right? And not the source. And so we want to say, oh, I can see now that, and it's fine to say, I didn't mean to say that. Some people are kind of wondering about the intention of the person, but the focus really should be, I can see that I didn't mean to say that, but I can see that this could be really hurtful. And I'd really like to learn more. So I'm going to try to learn more so I could work on that. And if somebody does point it out, to be appreciative as opposed to being defensive and say, like, what else do you want me to do? I didn't mean it. That kind of thing is not helpful. So instead being appreciative, saying thank you. And also just don't rely on the recipient to be the sole source of education, right? Because again, when somebody is just become the recipient of a microaggression, they might experience microaggressions more than other people. So this might be a more frequent thing than some others. And then also it might be that the range of impact could be from mild to kind of severe, and they might be sort of really affected. And it might be hard for them to then educate at that moment. So some considerations as responding to an upstander is that, there isn't one right way to respond as an upstander. So every situation is different. And I'm going to present a number of different response strategies, and so that you can just think about your style and what might work best for you to implement. Consider the safety of all the individuals and the timing. Is a patient agitated? Is there substance use involved? Are there sort of immediate safety concerns that need to happen? And then you also want to consider the threats to all of the people on that triangle, right? So we want to think about how can we address the microaggression? Let's say this happens in a team setting, and then also consider the threats to everyone. So the recipient, for example, can be seen as oversensitive if they sort of did bring that to the attention, or if they seem affected, or people have to sort of, address them. The source can seem sort of biased or also insensitive. And the bystander, if they don't act as an upstander, may be seen as a coward. And so there's really threats to each person on that triangle. And you really want to think about, how do you rebuild? How do you debrief? And you might not have the right words, but you want to try to be cognizant of that this is something we want to try to think about and brainstorm on how to do better. Here's one of the two models I'll present, which is really the stop, talk, and roll. This was developed by Dr. Susan Chang at Georgetown for medical students. And the STOP, and you've seen this in different bias training. I just had to do the child mandated abuse training, and there was like a pause, and so pause, and it's also on our Columbia training, like the pause and taking a minute to just stop and pause prior to response really helps. Again, this content can be inflammatory. What just happened? You want to reflect on words that you could think of to use, or how you want to strategize, and again, to which one of these strategies you want to use. The talk involves then trying out some Upstander skills if you can with the source. If you're not ready for that, you can just talk it over with a colleague or a peer, supervisor. And then the role involves, further talking that over or getting some help. You could debrief with peers or advisors or mentors. You can use some of the different systems to sort of reporting mechanisms. In the medical school has one, GME has one, Columbia has one as well. And you can talk to people from the Office of Professionalism, our Ombuds Office, Office of University Life, Office of Institutional Equity. So there's lots of resources in the environment. This is the second model. And so this is the 5 Ds of Upstander response scripts. And just, particular example on hospital rounds at the bedside, a patient refers to a trainee and says, "Get her out of here. I don't want any," uses profanity. "I don't want any, trainees in here." And so the direct approach is setting limits, being, just approaching the patient directly, saying, "Listen, let's be careful of our words here. We respect all people. We don't use that kind of language." The distract approach is to sort of ask an unrelated question to distract the source away from that bias. So you might say, let's shift the conversation, or, make an observation that's totally unrelated to move the conversation. Sometimes you might want to do this instead, because you might need something right away from the patient. And so you might want to use this to move that conversation away from bias so that you can get sort of the immediate thing that needs to happen with the patient, and then you can circle back. That's one example of how to use this one. Delegate is to seek help from a third party. Sometimes you're not sure what to do. These things surprise you. It come out of nowhere. You're just not sure what to say or do. And you can just say, hold on a second. We'll be back, and we'll get somebody else, or we'll get another person from your team to come in. And to document is just to discuss or document the incident, to discuss it with someone else. It's helpful, again, to process what you might say or do, also to see if there's something else going on with that patient that we want to check in to, if they're increasingly agitated or other kinds of things to evaluate. And then delay is check in with the recipient of the bias. And the people have asked, why is it delay? It doesn't mean that it's necessarily delay. It's just that you might want to do one of the others first. And then after sort of things have quieted down, or if you address the microaggression, you circle back to the recipient of the bias. And this is really important because, again, in that way, when there's the elephant in the room, you want to make sure that you're reaching out and you're intervening. Okay, and so then a few more, and then we'll apply these to some cases, okay? So we talked a little bit about education. Some people think, oh, this is what being an Upstander is. I'm gonna need to educate you and tell you what the content is behind this microaggression and what you should do differently. That is one way to approach it, and it's helpful because then somebody learns something, but it's not the only way. And again, remember, not everyone is able to do that at that moment, or really has the bandwidth to do that. And so again, some people experience microaggressions much more commonly than others, and so they really can't spend their entire day just educating after each microaggression they experience. But you could say things like, I can see how you might think that, and then provide some more information. One of our medical students said, and you'll see an example of this demonstrated, said, frequently gets confused for a non-MD member of the team, and said, oh, I'm flattered that you think that I'm, a nurse, but I'm the doctor on the team, for example. So you provide education. Paraphrase and reflect is just sometimes somebody can hear something back and think, oh, that's not exactly how I meant it to sound or to say. And so you can just say something like, oh, so it sounds like you're thinking this, or So what you're really saying is that right? And then somebody hears it back like, no, that's not right. That's not what I meant to say. And that's fine. And then they can think about that. We talked about impacts versus intent. You can say things like, you may not realize the impact of those words. Again, remember, many times people don't actually know why this is a microaggression. Or hold on, I need a minute to just process what you just said, or I'm really uncomfortable with that when you said or did this. And then you can come from inquiry or curiosity. So help me understand your thinking, or what did you mean by that? Can you say more about it? I want to better understand your statement. Can you explain it to me? And it sounds like we're assuming X. What if we assumed Y instead? So this is just a summary page. You can take a photo of this, and as I'm going to show you 2 sample cases, and you can use some of these strategies that I just mentioned to apply these to the cases. Oh, here you go. It's okay. Okay.
Come in.
Good morning. Hi, Mr. Williams. How are we doing today?
Well, good now that you're here, sweetie. You're the prettiest nurse I've seen in a while.
Oh. I'm flattered you think I'm a nurse. We have the best nursing staff on this unit. I'm the doctor, though.
Oh, wow. I didn't know they let beautiful people practice medicine.
Are you sleeping at all?
Sure. I was dreaming about you all night.
All right, Mr. Williams, now you're making me a little uncomfortable. I'd like to focus on taking care of you. So, let's talk about your pain, which is why I'm here.
Okay, so let's just have a little bit of discussion. We can just go over really quickly who are the elements on the triangle. So feel free to just raise your hand, call it out, it's fine. Who in this scenario, so there's Dr. Smith and there's Mr. Williams, only 2 people in this scenario. Who is the source of the sort of microaggression here? Mr. Williams, and who's the recipient? And who's the upstander? Yeah, Dr. Smith. So she's her own upstander. Sometimes nobody else is available and you have to do it for yourself, right? And then what upstander strategies are you seeing being used here? She demonstrates a few because he keeps persisting. So, yeah. So one's the pause, right? You see the pause. She pauses. She's like, braces herself, clicks her pen. Maybe she's thinking about what she might do next. Did you have a question? Yeah. Any other, what examples? Yeah, Alex. Yeah. And what does she say? Right. And so she does that. And that's directly from like a trainee who participated in this training earlier on. And I thought that was such a respectful way to provide the education without sort of denigrating anyone else. There's nothing wrong with being assumed to be somebody else, but you do need to state your correct position for the team, on the team. Anything else that you see demonstrated by her? Yeah. How does she do that? That's right. And so she's like, let's try to move away from this and let's just focus on something else, right? And ultimately, what does she do? Yeah. Yeah. And she's like, okay, I've tried like lots of indirect strategy. She tried a direct strategy. She tried some indirect strategy. And now she's just like, let's focus on, this is making me uncomfortable. And let's focus on taking care of you and your pain. That's why we're here. And then moves on. And then it seems like he's amenable to that. Any other thoughts about this scenario? Yeah, Alex. Oh, okay. Okay. Next time. Yeah. Okay. Okay. Next for the next video. This next video is a little bit more, there's a lot more going on. Any other feedback on this before we move to the next scenario? Yeah. Okay. Not too many. Okay, never heard that one before. Okay. It's good. People react. It's good to hear what people are thinking as they react. So, oh, she said two things, which were one is that she might want to tone things down, but instead of saying, how are we doing when it's just the two of them, really she's asking about him. How is he doing? And the second thing was about the neckline and maybe wearing a higher neckline. Okay. Thoughts about that? Yeah, I think it's important to address that one. Yeah. Right. And so people will have different reactions to how you might be dressed, how this character is dressed in here. But it's not as if she's inviting these commentaries or and in her style, she has a blue scrub top underneath, and then she has, it doesn't seem, in my opinion, too low. So I don't see that. That wasn't, we did create these videos, so do have a hand in creating it. We didn't, create this as if this was sort of suggestible or anything. But even if, again, as long as she's not violating any professional boundaries, we want to people are not inviting microaggressions because of their style of dress necessarily, or their other aspects of their identity. Any other comments on this video before we move on? Okay. Anything online, Alex, you want to share? Okay. We'll go to the next one.
Hi, Aaron. This is Luis Hernandez. It's his first day rotating here this month. Welcome.
Hi, Dr. Anderson. Actually, Luis Hernandez is a trainee in my program that is rotating in the emergency department this month. My name is Anthony Garcia.
Oh, I'm sorry. I mistook you for another trainee.
Hi, Anthony. Welcome. What are your goals for this rotation?
I'd like to learn more about community health.
Oh, this next case would be perfect for that. Looks like she's getting her frequent flyer miles in. It's her third visit in 3 weeks. This is a 42-year-old woman. She comes in with neck and back pain that radiates to her arms, legs, and head. Basically TBD.
TBD?
Total body dolor. Anthony, let's go in and you can translate for us.
Sorry, my level of Spanish isn't sufficient for a clinical encounter, but I'll call the interpreter service.
Thanks, Anthony. We'll definitely call that interpreter service. It's against our policy to ask students to translate. We want our students to focus on learning, and we need to use certified interpreters to improve quality of care. Terms like frequent flyers and total body dolor are biased. They can cloud our judgment and make us miss things like a worsening condition or new problems.
Okay.
Okay, so if we think about that scenario, just again, there's a few different things going on, but who's the source of the bias here? And you can pick, there's more than one. The patient, somebody said, and
the student.
And the student. Okay, that's right. And those are the recipients. Right, those are the recipients. And who's the source?
Dr. Smith.
Dr. Hilary Smith, right? And then the upstander?
Dr. Anderson.
Dr. Anderson, anyone else? Yeah, the student. And so let's just take it from the beginning. What do you see first happening? What's the sort of a misconnection there? It's the first thing that you see happening. Right. So she confuses him that what Prudence said was she confuses him with another student, right? The students have similar kind of Hispanic sounding last names. Perhaps that was leading to some confusion. It's one thing. And then the student is, again, upstands for himself, provides education, oh, that's a different student. He's doing this, rotation in the ER, and then identifies who he is. What is another example
If I
here?
could just interrupt for 1 second.
Yeah.
If folks could raise their hands so we can get you a mic, that way people online will be able to hear too.
What is another point here that's happening that you notice, like microaggressions here?
Well, asking the student to interpret when he's not a certified interpreter.
That's right.
Just because he has a Latino last name.
Exactly. So there's no evidence that the student knows how to interpret. Are they a certified interpreter? We don't know. And also, why are you just assuming that he speaks Spanish? Is it because of his last name? Perhaps. So want to be careful about that. And then he also provides education. My language skills are not sufficient for a clinical encounter, but I'll call the interpreter. And then what else? What other kind of microaggressions are we seeing? Yeah. Do you want to?
I mean, she interrupts him, right? He's like, I'm really excited about this community health rotation. And she just jumps right in, which I thought maybe plays into the whole relationship that they've established or that is happening. But I thought that was a really sharp interaction.
What else did she say also about
and then she jumps into speaking about a patient in a relatively negative fashion.
Right. So she used terms like total body dolor, frequent flyer, those kind of terms. And then who is the upstander for that scenario? Yeah, John.
I was actually going to make a different comment if I could, which was that it wasn't just her verbal comments, it's her nonverbal behavior, rolling her eyes at one point as well.
Okay. And so there's verbal and nonverbal as well. What and who was the upstander and what was the upstander? How was that done? Yeah.
So Dr. Anderson, if we're talking about, I guess, maybe some of the good things, it was very matter of fact. It wasn't putting the student on the spot, and it was just addressing it directly.
Okay, so he provided education. Now, some people don't agree with that. With that kind of. Does anybody have a different opinion of sort of how Anthony Anderson? Yeah, do you want to say more?
Hi, I honestly feel mixed or conflicted about it because I worry that when the upstander combines the feedback for the comments that are made towards the student with the comments that are made towards the patient, in the source's mind, I worry they're going to associate sort of the injury of that all with the student, which might not actually create the safest environment for the student. So I don't know, maybe separate timing of feedback for those things.
That's right. And what else could you do differently, right? So one is to separate those two kind of out. And what else could you do differently here than what Anthony Anderson chose to do? Yep, right in the back.
I think a different approach could be Dr. Anderson could speak more privately with Dr. Smith.
Right.
Because sometimes when giving these feedback in a public setting, the person receiving the feedback can react in a negative way. And again, kind of to the point of what Cal was mentioning, I think it could also create a very tense and stressful environment for the medical student.
Exactly. So you have options of how to do these, how to make these comments. Nothing wrong with what he said, really, but how he said it, when he said it, how he decided to say it. You could choose different things. You could choose to do that privately. You could choose to separate those two things and to just one part there. One thing that comes up a lot with our faculty and our students and our trainees is that the faculty are worried if they don't address it. Well, they sometimes don't know, they're not sure how to address it, but they are concerned that then the team or the students or the trainees will think that they are kind of going along with what was said, and how can they have an opportunity where they sort of indicate that they're going to check on that later. And it's just that by saying that, right? To say like, this is what we do clinically. We're going to say, okay, here's how I'm going to prioritize. This is the first thing I'm going to do, the second thing, and the next thing. So it's the same thing. It's like, you could tell them later, I'm going to talk about that. I did hear these words, frequent flyer, total body dolor. I chose not to do it to address it together while you were you were there, but I am going to talk with Dr. Smith, later, and to really address those, because that's not the kind of comments that we want to use for these very reasons. He also did provide a reason why it's not good, right? Like it can it can bias our kind of thinking, decision making, and foreclose kind of what we're thinking about our options for this patient. So those are some options. Any other feedbacks, comments? Yeah.
I just want to read this comment that came in on the chat. This is from Andrea Badillo Perez. She says, "Hi, Dr. Alves-Bradford. I'm a medical student at NYU listening in today. As a Latina trainee, this scenario resonated deeply with me. There are many times where something similar has happened to me, and it would have meant a lot if someone had been an upstander as seen in this video."
Thank you. Thank you for sharing that. And that's exactly why we're doing this. So this happens a lot. One of the things that is sort of just stated, but not really explained too much in this video, is like the confusion of two trainees with maybe similar Hispanic sounding names. Very frequently, trainees are mixed up, for same race and gender trainees are confused for one another to the extent that sometimes the trainees aren't sure really that they're getting the evaluation or grade that was actually meant for them. They frequently receive kind of feedback or comments about something that happened and they were not there that day, or they were not at that location. So there is a reason, that just I wanted to highlight two kind of learnings from that scenario. There is a reason, right? There is this other race or kind of cross-race effect that we are better at recognizing people who are from our own race or racial background, and that it's harder for us to separate or to distinguish between people who are from different or other races than our own. And so just knowing that exists, again, there isn't shame or blame. We all are the source of bias at some point. And so knowing that exists, what has some tools that have been helpful is really to focus on certain characteristics. Sometimes I say it's like kind of like twins, where you have to focus on some characteristic that's more unique for one or the other, and then the other thing is just some tool. So sometimes we're really trying to implement things like just like name cards, or people are seated around for didactics, just kind of place card with names and things like that. And then also just, again, that's the point of the person-centered language, using more strengths-based, not deficit-based. Those pejorative terms like total body dolor or frequent flyers can really negatively impact our decision-making. And using more person-centered language. Just have a few more slides, which I want to talk to just to tell you what our mistreatment mitigation activities are. We are tasked by the AAMC to have a process to respond to mistreatment, and we do have that. And so we review the data that comes in with the other Office of Medical Education deans. We provide loop closure, so we respond to 100% of reports. And we have each department has a senior faculty learning environment advisor who helps to communicate any of the reports to the individuals that might be named. And then we provide annual reports to chairs with comparative data. And we have affiliate sites, Bassett Health, Stanford, Connecticut, and Harlem Hospital. And we make visits to those sites as well, because they're students. And we're to surveil the learning environment and get feedback from the faculty and leaders there. And then we really try to develop this culture in which students and others feel safe reporting, and identify strategies to improve our learning environments and provide tools. We do have a learning environment committee, which is chaired by myself and Dr. Jean Iman from surgery. And we make recommendations. We sort of look more strategically at what's happening as well, trying to make recommendations for how to improve the learning environments overall, and implement new initiatives. And I'll tell you some of those things. One is the Positive Learning Environment Survey. This is for our students to, one of the features of the healthy learning environments is to recognize exemplars. So we want to recognize the positive things that are happening. It's not just mistreatment and learning in hostile learning environments, but we want to think, just capture all of those wonderful comments. So we have that, and we do share that out when those comments come in as well. And so we also have created new Outstanding Clinical Learning Environment Awards. The committee was really, again, trying to recognize exemplars in our learning environments. And you may recognize some psychiatry people up here. And so I really wanted to just shout out Abby Domseth, who won 2 awards, both the Gold Humanism and Excellence in Teaching Award. These are awards nominated by our students. And also one of these the Gold Humanism Awards have been, those are not new, but she won the one for the residents, and then and for the staff, we also had Glenna O'Keefe, who won the Gold Humanism Award for the staff, and Abby really won 2 awards. So one was the Gold Humanism, and one was one of these new Outstanding Clinical Learning Environment Awards. So really grateful for the work that she's doing with her students, as well as Glenna has been doing for a number of years as well. And then we also have this Upstander Train the Trainer. So this content has been shared with our students. It's been shared with, and we're really working to share it and to support these kinds of things that happen across our learning environments in the different departments. A group of faculty have signed on to sort of get more information and learn more and how to do these kinds of trainings to support these skills, to support the kind of these microaggressions that happen in the departments. And they have participated in this Train the Trainer program. And if people we're having another cohort, so people are still interested, which is great to sort of see. And so if people are interested in participating in that cohort, please use the QR code and sign up, and we'd love to see you and to join. And we have a community of practice with people that you see on the screen, including Felipe, who's part of it as well. And that's it for me. If you wouldn't mind completing the post survey, I'd love to take any questions that you might have. Thank you so much for your participation.